According to the World Health Organization, about 15 million people die prematurely every year across the world from non-communicable diseases. 85% of these deaths occur in low and middle-income countries. In Africa, about 2 million adults die every year just from complications related to diabetes and hypertension alone, of whom 3/4 are under the age of 60. Non-communicable diseases are not only a health problem, but a global development challenge. Even if patients can access limited services and medicines, the high cost of care forces many people into poverty due to increased expenses that they incur to access health services and poor health effects of these diseases.
The burden of non-communicable diseases is on the increase in Uganda, and this is evidenced by data that is coming from our health facilities, but also from other studies from the academia and from other surveillance sites. For example, in 2014, we did a study and we found out that 24.3% of adult Ugandans, that is 1 in 4, have hypertension, and 1.4% have diabetes. The same study showed us that actually in the urban centers, up to 3% of the adult population has diabetes.
It is the poor countries and the most vulnerable in their societies who are most affected by non-communicable diseases. Diabetes and hypertension need lifelong treatment. If these conditions are not managed effectively, then patients can go on to develop serious complications such as cardiovascular disease, kidney disease, blindness, and foot ulcers that do not heal. As such, the consequences of poor control are serious for both the individual and society.
On the individual patient, these conditions put a strain on their finances, their quality of life is reduced, and eventually some die prematurely.
The problem of rising hypertension and diabetes in Africa is occurring alongside a high burden of HIV. HIV is now a chronic condition with patients in lifelong monitoring and care, much like hypertension and diabetes. We believe it is practical and could be financially beneficial to integrate the care for HIV, diabetes, and hypertension, as these three conditions share severe essential elements for prevention and management.
So integrating is the way to go. We should have a one-stop. Of course, when you go to see a doctor about HIV, do you leave the other body which has the diabetes at home? You go with the same one body. So we should integrate, and this makes sense. It will even reduce the issue of stigma. So when I go to Mulago, or go to Naguru, or go to any health center for people who don't want to be known as having HIV, they can go to the same clinic as people who have diabetes or have the pressure.
HIV requires lifelong chronic care, and HIV programs have had much success in providing treatment and care to patients.
What has happened is that ever since they adopted the policy of test and treat in 2016, many of the people have gone on to ART, that is antiretroviral treatment. And that has translated into many people now not dying, but having the will to live. So people are no longer dying from HIV.
Majority of people with HIV are receiving antiretroviral therapy and have excellent control of their condition. Unfortunately, the deaths from diabetes and hypertension are already at the peak level of deaths that were seen with HIV in the early 1990s. And these numbers are rising. We must address the access to health and cost of care for patients with chronic conditions.
Nti ffe kubanga tugenda kubeera ku ddagala ebbanga lyonna ate ne tusigala nga tufulumya, twalisabye naffe tuloozebweko nga aba art bwe baakola ki, bwe baba providinga n'eddagala ku bwereere.
Unfortunately, Only a small number of people with diabetes and hypertension receive regular care, yet these two conditions are responsible for an increase in heart disease, stroke, and kidney disease. Chronic diseases also cause disability, including damage to the nerves.
We have to move towards integration because with non-communicable diseases, you either prevent at a minimum cost or you treat and rehabilitate at a maximum cost. Providing care at primary level, which involves meeting this patient in the community, analyze their kind of risk factors they are exposed to and give them tools to change their behavior is very key. We need to apply the lessons we learned from HIV program to manage non-communicable disease programs.
63-year-old Prosi Naluboa has been living with HIV for more than 20 years. She was one of few people to be started on ARVs as early as 2001, before they were widely available in Uganda. She was diagnosed with hypertension 2 years ago when she suddenly became unconscious and got a stroke at her mother's burial.
Baba bamuteekayo n'entunulayo bwenti saamanya kyankuba n'engwanga wali amagezi ne ganzigwamu ne bansitula ne bawujja ne banteeka mu mmotoka ne banziza e Kampala ngenda okutuuka wano ne banteeka mu kilinika awo nzira engulu mbuuza nabadde ki ne bagamba pressure.
53-year-old Mustafa Kayondo has been living with diabetes for 25 years, having been diagnosed with the condition in 1995. He decries the high cost of medication for his condition.
Singa batuyamba madamu ne mutuyamba ku kintu ekiyitibwa obujjanjabi bwa ssukaali diabetes. Oba oli emmere tuyinza n'okwenoonyeza kale. Naye eddagala era ekibatujjako ekireeta ffe tufe kwegamba eddagala lirya buseere nnyo.
For the participants living with diabetes and hypertension, being part of the studies gave them an opportunity to be assessed for any hidden conditions other than those related to HIV and to access some medication and support. Findings from this pilot study suggest support for integration of services from both healthcare providers and patients, but this needed confirmation in a larger study.
Omulwadde wa siriimu n'owa ssukaali gwe bw'oba olaba enjawulo ki nze mbeera ne ssukaali wange obulamu bwe bwonna ate nno ky'otannaba kumanya nze nina ne be baŋŋaana okulya nina condition ze ntambulirako owa siriimu alya buli kyayagala kyonna n'akisaawa ate eddagala n'afuna lya bwereere kwegamba mu bumpimpi osanga ate owa siriimu ffe ate atusingako.
We are trying to provide integrated care for our HIV patients and patients who have what we call non-communicable diseases, such as hypertension and diabetes, so that if a patient is coming for their drugs, for example, for ARVs on a particular visit, and those individuals also have other diseases like diabetes or hypertension, you don't have to burden them with multiple visits to these health facilities. They should be able to come, pick their drugs for their ARVs, for their HIV condition, but also pick their drugs for hypertension, for their diabetes, or any other health condition.
However, it may carry risks. Bringing services together might adversely affect HIV programs because the focus would now be broadened, or patients with diabetes or hypertension might feel stigmatized from going to the same place as people with HIV.
Before we scale up this integration model, we want the research to tell us, in a real life scale up, how well does integration management work? What happens to the outcome of people with HIV, with diabetes, with hypertension? What are the costs in the real life setting? Does stigma, for example, reduce or increase? We will need this information to verify the new model of care before we do the national scale up.